of subspecialty palliative care doctors is to help the primary doctor, who's the person who's really in charge of the patient's care, to try to improve the patient's quality of life. And there are basically three main things we do. First is we try to work and decrease physical symptoms. Second, we try to decrease psychological or psychiatric symptoms like depression or delirium or anxiety. And third, we try to meet with the family and patient. And if they want, and the primary care doctor wants us to, we'll talk about what the future might bring and how to make sure that they're prepared. We see patients anywhere in the spectrum of their illness, so from people who have recently been diagnosed with cancer, to patients awaiting lung transplants, to patients who are in the ICU, where we basically are helping run family meetings. I think the way it's changing is that we're much more involved in helping with symptom management. So for example, we see a lot of the cancer patients who have really severe cancer pain and help with their cancer pain, help with the anxiety and depression in conjunction with our psychology and psychiatric colleagues, which I think is a new thing. I think people used to think of palliative care as largely doing family meetings and sort of talking about goals. We'd much rather see people early on and develop a relationship with them and their primary care doctors to try to build a sort of good team so that regardless of what happens, everybody is prepared. We've gone from written records to electronic records, and in some ways that's been a great thing, and in some ways it's made it harder to find things that you really need to find. And so when patients go from a nursing home to a hospital or from a hospital back to their doctor's office, often their goals and the previous discussions about goals have been hard to find in the electronic record. So we're working with our IT group to make it much clearer and to make it easily found and identified. And that's something that's going to roll out in the next year or so at the UPMC hospitals and then into the long-term care facilities as well as doctors' offices. If you look at the data, and there is an increasing amount of data, that having subspecialists either consult or co-manage the patients results in patients who have less symptoms, in patients who are more satisfied with their care, with family members who are more satisfied and have less psychiatric illnesses, as well as in one study, having palliative care involved in patients with metastatic cancer meant that they lived longer. If you have a patient with a serious illness who has either physical or psychiatric symptoms, or you are worried about how their or their family is coping, or that they don't really understand what might be coming next, think about whether your palliative care service could help you provide better care to that patient and family.